Good evening. Hope everyone is doing well. My name is Dr. McAvey. I am a double board certified OBGYN. I'm practicing in New York. I'm part of RMA of New York, which is a very large fertility practice that originated in Manhattan and spans out to Long Island, which I am a part of. And then we also have large practices in Brooklyn and in Westchester. So I am here to talk to you all about really preconception, things to think about for those individuals who are thinking about trying to conceive. For most patients, I would say in today's day, things are a little bit more calculated and planned, which is good because it keeps your sort of timeline in place. And so I do think that's part of the thought process is, when are you thinking about trying to conceive? How old are you at this, juncture in life? And what should you be thinking about before you actually go forward and try? There are things to think about. Some patients don't think about anything and just get pregnant, and a large, vast majority of the time, everything is okay. Um, and there are some patients that really want to take control of their health and take control of their, reproductive health, specifically, and sort of check some boxes, just to make sure everything is in order before they go forward and do what is probably the most important thing, right? Try to get pregnant and have a healthy pregnancy, with the goal of having a healthy, live born. So, um, I was sort of in that boat. I would say I was, calculated. I kind of knew when I was going to try to conceive, and I was thinking about things beforehand. Um, so I would say timeline is important, and taking into account your age. If you're 30 years old, you probably have some time. There's likely no rush, right? If you're maybe trying to conceive for the first time and you're thinking about it and you're 37 and you know that you want, more than one child, maybe time is of the essence, right? And it's something that you should think about doing sooner rather than later. Um, so timeline is important. Things to think about in terms of health status. So I typically would break it down into GYN health, so gynecology health, and non-GYN health. So GYN health meaning, are you on a birth control pill? Do you have an IUD in place? These are important things. Patients that, for instance, have an IUD in place because they're trying not to get pregnant, or maybe they have heavy bleeding and they needed the IUD to, decrease bleeding. Um, for those patients, you don't just sort of take out the IUD and try that month. Often patients with a hormonal IUD don't have a period at all. So I would say for the patients that, let's say, have an IUD, take it out, give yourself 3 months, and let's see what happens with your cycle. Do you get a period back? And then what's the pattern of the periods, right? So trying to sort of map out your cycles. Some patients take out an IUD and it takes a while to get a bleed. So that's important to think about. And then same for birth control pills. I'll see patients come in, they're literally on birth control pills for 20 years, which is fine. There's no harm to birth control pills. It's actually a very good thing to be on a birth control pill for many reasons. Ovarian cancer prevention, it's good for your uterus, it's good for your skin, it's good for your bones. But, sometimes if you're on the pill for a very long time, same thing, you come off of it and then you have what's called post-pill amenorrhea. You don't get a period right away. You have to wait 6 months to get a period. That's sort of on the longer end, but it's not unusual. It takes a few months to get, your cycle back. So, if you're on some sort of contraception, think about that in advance. Most people don't stop the pill and get pregnant that month. Could it happen? Of course. But, so those are the two things I would think about. Staying in the realm of GYN, have you seen your gynecologist? Do you have a normal pap smear? Patients that have a history of abnormal paps, which is extremely common. Most sexually active people have been exposed to HPV. They may have had an abnormal pap in the past. Maybe they have HPV. You do want to make sure your pap is normal. You don't want to get pregnant and then be dealing with, an abnormal pap when your first trimester. It's very stressful. The GYN doctor typically will do a pap smear in the first OB visit. So make sure you've seen your gynecologist. Um, and the other thing to think about, again, in this sort of this, reproductive arena is, preconception genetics. Genetic screening has, very much taken over medicine, not just for reproduction, for cancer, right? Cancer is all genetics. Um, Autoimmune disorders are genetics based. A lot of diseases now are linked to specific genetics. And when we're talking about conception, the things that we think about are autosomal recessive disorders. So meaning, most of us as humans carry something. So for instance, my family all carries something called cystic fibrosis gene. I actually had two aunts who were affected with cystic fibrosis and unfortunately died, my dad's siblings. So my dad's a carrier, my sister's a carrier. I didn't know if I was a carrier. I had a 50% chance of being a carrier. And it's a very common carrier gene for Caucasians. So I think it's even like 1 in 20, it's quite high. So, you have to think about your family history. Are there any genetic syndromes in your family? Have you had any remote, parents, siblings, or grandparents that had health conditions? Um, and then honestly, even for the patients that don't have a health history, have no family history of a genetic disorder, the standard in today's day is to do preconception genetics. So not just, cystic fibrosis is sort of the common one, but it can be sickle cell trait, it can be deafness, thalassemia, um, you know, it goes on and on. I mean, the panels now, we use expanded panels are testing for almost 400 disorders. Because it's what's called autosomal recessive, if you were a carrier of something, which most of us carry something, you just want to make sure that if you have a male partner, the male partner does not carry the same gene because it's two to tango. You have to have two, sperm and egg source carry to have an affected baby. If you're a female that's using a donor sperm, all the donor sperm banks screen on the same genetic panel. So I would strongly suggest preconception genetic counseling. If you don't do it and you end up pregnant, it's okay. Your OB would do it at that first visit. If you were a carrier, then they would screen, if you have a male partner, the male partner. Obviously, if you were using a donor sperm, you would be coming to somebody like me or one of my colleagues, and so we would do the genetics. So, that's something to think about. Also, in the realm of genetics, I'd mentioned like cancer, breast cancer is obviously, unfortunately, very prevalent. Breast cancer in young females has been linked to, again, genetic mutations. So if there's a strong family history of breast cancer in the females in your family, or ovarian cancer or colon cancer, usually, in this day and age, you would have had somebody would have had genetic screening completed. And so if there is a known, if there is somebody known, let's say, who has BRCA, that's something you have to weigh. Do you do genetic screening on yourself preconception because it might tailor what you do, meaning spontaneously get pregnant, or don't try to spontaneously get pregnant and go down the route of assisted reproduction to screen out the genes. So I do think genetics is very important to think about. Sometimes it's overwhelming for patients and they really don't want to do it, and that's okay. It's just, there's no crystal ball. And if there was a prediction that you could be a shared carrier of something, you'd rather know before than find out pregnant. Because then if the male partner is a carrier positive for the same gene, now you're dealing with an amniocentesis at 15 to 18 weeks pregnant, and it can be very stressful. But to level set, the chance you're a shared carrier is under 2%. But I see patients every day that come in with it. Okay, so timeline, whether you've been on an IUD or birth control, the genetics, regular health routine stuff, like pap smear I mentioned, especially if you have a history of an abnormal. Other things preconception, so non-GYN realm. So things that I think about are, immunities. These are things like we don't think about, you don't think about until you're pregnant or trying to get pregnant. So you want to be immune to measles, chickenpox, and rubella before conception. There has been a shift lately in some, dynamics, especially in the New York area. It's extremely populated for some groups to not get a measles vaccine, and which is a different conversation. But the reality is there are measles outbreaks. If you were non-immune and you were pregnant and exposed to measles, it can be devastating to the fetus. So generally, you would want to check and make sure you're immune to Chickenpox, rubella is also devastating if you don't have rubella immunity. Most of us in the United States have gotten MMR, measles, mumps, rubella, as on our sort of, if you're especially in the public schools, or for colleges, you have to be. So most of us are immune, but you sometimes need a little booster. They are live virus boosters, so you can't get pregnant for 30 days after taking a live virus booster. Things like flu or hepatitis, those are not live viruses. If you're non-immune and your OB wants you to get a flu vaccine in pregnancy, which is highly recommended, that's safe to get, but you can't get chickenpox, rubella, and measles. So those three things, it would be nice to know if you're immune. Your general doc could send it, or your general GYN. Other things to think about, vitamins, vitamin deficiencies. Most of us in the Northeast or in, cold climates are vitamin D deficient. So patients who are vitamin D, whether they're, especially those trying to conceive, you would take a vitamin D supplement. Iron, most of us who menstruate have iron deficiency in some sense. You just want to make sure it's not extremely low. I see patients come in trying to conceive and they actually have an inability to conceive, right? And they're coming in for an infertility consult. And we always check what's called a complete blood count, a CBC. And you'll see they're anemic, and then you'll see their ferritin is low and they're iron deficient. So they should take iron, right? It's nice to be sufficient in vitamin D and iron prior to getting pregnant. Pregnancy in and of itself will cause you to become iron deficient. So a lot of prenatal vitamins actually have iron in them. And that's important when you're trying to conceive, select a good prenatal vitamin that has iron in it. And then the other the prenatals have calcium, very important, obviously, the vitamin Bs, a lot of people are vitamin B12 deficient. And then obviously vitamin D. So prenatals, the most important ingredient of the prenatal, hands down, is folic acid. And that's the guideline from American College of OBGYN, is that the patient should take 800 micrograms of folic acid. Most standard prenatal pills have that at minimum. Usually it comes as 1 milligram, so it has what it needs. But if you're not going to take a prenatal that includes folic acid, which it always does by default, you should at least take folic acid. So that can be purchased separately, but I would just recommend a good inclusive prenatal vitamin. Patients often will ask, is there one you like better? I feel like we're sort of targeted, on the iPhone. So if you're somebody that's trying to conceive, your phone's going to know that, and then you'll start to get advertisements for the prenatal vitamins. There's a variety that are, Nature's Made, and I think patients like Ritual, and they like Perel and luminary vitamins, and Theralogic. So there's all sorts of nice vitamins that exist. They're all nice, whatever you can, they're all similar price point, can be purchased online. But a good prenatal with folic acid, and nice to have iron in it. So that you should take a good 30 days before trying to conceive. It's also good for your hair, hair and skin and nails. So again, going back to, the sort of non-GYN thought process. So besides the immunities, the other things we think about. So obviously anybody with a chronic health issue, things what we think about, thyroid, right? So if you are someone that has hypothyroidism or hyperthyroid, very common, extremely common is hypo, meaning lagging thyroid, very common. You want to make sure you have adequate thyroid functioning. Once you're pregnant, your thyroid requirement goes up by at least 30%. So for patients who are on thyroid replacement, often once you're pregnant, the medical endocrinologist and the OB will increase your dosing. So I would say that's important to think about. Patients who have uncontrolled thyroid have higher rates of miscarriage. And in patients who are undiagnosed and get pregnant and then get diagnosed in pregnancy, there are, sort of poor outcomes in terms of the pregnancy. So we want to make sure, especially if you have a history, make sure your thyroid's in check. Sugar levels, right? So high sugar levels are not great pre-pregnancy. Weight is obviously, it's a chronic issue for a lot of patients. Being overweight, there's a large percentage of patients now on sort of the weight loss journey, specifically using the GLP-1 class of medications, which is revolutionized weight loss. And, as a fertility doctor, I'm extremely in favor of a patient if they, are overweight or have obesity, meaning they have a high BMI, body mass index, which is weight as a function of height. It's important if you're going to try to lose weight, it's pre-pregnancy. I have patients, who will get pregnant, say, can I go to the gym now? It's like, it's not the time to sort of diet and work out once you're pregnant. It's like the ship has sailed. So if there's a concern for weight, which is a concern for many patients, we want to address that pre-pregnancy. Patients will come into me, again, not able to conceive and the weight is quite high. And if they're young, I'll say, let's like not do treatment for 3 to 6 months. Let's focus on the weight, get the weight, because once you're pregnant, the higher the weight is at the start of the pregnancy, all patients gain weight in pregnancy. That's part of being pregnant. So now you're gaining 20, 30, 40 pounds. It just puts the patient at risk of, gestational diabetes. So diabetes in pregnancy, and then, big babies. Big babies lead to C-sections. There's sort of a whole downward, consequence of the weight. So, and then postpartum, you can have fluctuations in your sugar levels, and the baby can have fluctuations in the sugar levels. And then it's hard for everyone to lose weight postpartum. So it just becomes this whole thing. So, if weight is a concern, and no one needs to be a certain weight, but if the weight is a concern for the patient, or the patient was told that they have high sugar levels because of the weight, we should probably just try to lose some weight before pregnancy, if at all possible. Some patients will not do treatment, and actually they'll go on the GLP-1 for 3 to 6 months. The weight loss on those drugs is extremely rapid, whether that's good or bad, but it's good for sugar levels, I would say that. So weight is something to think about. And then underweight is also an issue. We always think about overweight patients, but underweighted patients have a tough time also. Underweighted patients often don't ovulate, right? They don't get periods regularly. They're often vitamin deficient. And they often have low bone mass. So these are very significant things that we need to think about. So underweighted patients as well, we really want the patient to be at a healthy weight, before being pregnant, if possible. Chronic health issues, other things to think about, if you're a chronic hypertensive patient, meaning you have baseline high blood pressure, there are certain medications patients are on that are not compatible for blood pressure, that are not great for pregnancy. And there are certain ones that are great for pregnancy. So there's often a switch of medications for someone that, let's say, has high blood pressure. Any chronic health issue that if a patient has an autoimmune disorder, lupus, rheumatoid arthritis, diabetes, high blood pressure, we want to look at the medication list. We want to make sure that they are safe for a fetus. The FDA classifies all approved meds based on pregnancy risk to a fetus, and risk of nursing. So expressing milk either with a pump or breastfeeding, again, is classification for a medication. So there's different classifications. FDA class A is something like Tylenol. It's been studied in randomized trials. It's extremely safe. You can take it. Class B is also safe. Class C, which a lot of chronic health issue medications fall into, are sort of unknown. So the idea of it is like, if you don't need to be on it, come off of it. But if you need to be on it, stay on it. An example of that would be like an SSRI, so an antidepressant or an anti-anxiety med. Most of the time, those fall into pregnancy class C. Most providers, GYN doctors, obstetricians, high-risk doctors, fertility doctors, psychiatrists, all feel the risk of coming off of an SSRI is too high. The biggest risk of postpartum, of depression and anxiety, is postpartum, right? Shift of hormones, no sleep, surgery if you have a C-section, caring for a newborn, no one knows how to do it until you've done it the first time. All very stressful. And so the risk of coming off is not worth the benefit. So the pendulum on that has shifted quite a bit. most of my patients who are on an antidepressant or an anti-anxiety, my recommendation is stay on it. No worries, stay on it. I don't think there's major risk, but technically it's a class C. The reason also the FDA classifies things in C is that they haven't done the randomized trials. So it's very hard to randomize pregnant patients to a drug, right? So a randomized trial means you take a placebo, meaning an empty pill, and you compare it to the active, let's say antidepressant. You're not going to get a group of pregnant patients say, yeah, let me randomize my child to, randomize myself to take, an antidepressant if I don't need to. They're not going to do it. So when there's no randomized trials that are published to document medication safety, it falls into C. But in terms of the antidepressants, anti-anxiety, everyone thinks that it's safe. But anyway, so reviewing your medical, history is really important. Any chronic health issues is important. Your medication list is important. Family history, genetic syndromes, preconception genetics, the immunities I talked about, the vitamins. And I think that's probably what that's pretty comprehensive. If you have a male partner, we'll go, men never see doctors, so the guys will come in, I'm like, when's the last time you saw a doctor? And they look at me, I never have. But obviously if you have a male partner that has similar things, chronic health issues, autoimmune disorders, they're on any sort of, significant medication, it's important to think about. Sometimes males are on steroid, they're on testosterone. I see that for, low libido, weight gain, feeling tired. I have many patients in encounter who show they didn't realize that being on external testosterone causes them to have no sperm. Poor patients trying for a year, they want to know why they're not pregnant. And meanwhile, he's taking a steroid. So not to bog him down because men sometimes think differently than females and they think that we overthink everything. But, if you have a male partner and that male partner has chronic health issues and or he is on medications, it's important to review those. Anything like toxic habits, smoking a lot of cigarettes is like let me rephrase. Smoking any cigarettes is horrible. No smoking. Heavy alcohol use is not great either. So tailoring that or decreasing it and then stopping smoking is always recommended for male and female, I'm sure the ladies on this talk are not smoking cigarettes, but that would be advised to stop. And then the males, also the genetic history. So, if you had a mom that had breast cancer, it's important to know that because again, even though she had breast cancer or ovarian cancer, she could carry a gene that he has that then could be passed to a child. So really his health history was important to know. And then, trying to go forward with attempting to conceive. So starting out, I would not overthink it. The only thing that I would note mentally is how often do you get a period? There are all sorts of ways to do that. Everyone has a phone. There's a million apps you can download. Which is the most I would do. So if you're inclined, you absolutely could download an app where you input your day one period and you input the next day one period and then maybe input the next. So like over a 3-month time frame, you'll very easily be able to see, do you have a period once a month? If you have a period once a month, you're likely ovulating. I mean, you're releasing the egg. If you have a 28 to 30 day cycle, odds are you're ovulating day 14 to 16. Easy. That's it. Sperm, if it were to be normal, and again, this is for those with male partners. So I don't want to, if someone has a female partner, you'll still think about the cycle pattern because that's when we would do insemination with donor sperm. But for the patient who's attempting intercourse with the male partner, the sperm can live inside the female tract for up to 5 days. So if you're someone that gets a period every 28 to 30 days, have sex. It can be every other day, day 10, day 12, day 14. That's it. You can track on the app. You really don't necessarily need to be using urine sticks, like LH kits. You can buy them in the store. I would say you don't need to drive yourself crazy and do that unless you are seeing that you're not able to get pregnant after a certain duration of time, or perhaps your cycle isn't regular, and now you're getting 40-day cycles, or it's 35-day cycles, or it's 26-day cycles, and it's not so regular. It can be frustrating. The kits that you buy in the stores are not perfectly accurate. They don't always read well. If you were to ever come into an office, a GYN or fertility doctor's office, we do ultrasound and blood work. It never lies. We don't need to interpret it. But those kits that you can purchase in the supermarket or in the pharmacy, the intention is to look for something called luteinizing hormone, and that's the hormone in the brain that rises right before you release a follicle, which is ovulation. I would not suggest doing it prior to day 10. You do it in the morning on day 10. You could do it once a day, morning on day 11, morning on day 12, morning on day 13, morning on day 14. If you're someone that gets a period once a month, you're going to start to see the surge. The surge will come in one of two ways. It can come in two lines. They need to be the same color. Or it can come as a blinking smiley face and then a smiley face. So if it's either digital or manual, that's how they're sold in the store. And that's it. Have timed intercourse and give it a few months. If you're under the age of 35, really try for at least 6 months, I would say, before you entertain seeing a fertility doctor. Over 35, sometimes patients end up coming in a little bit sooner, and that's okay. I think, again, given the family history or the medical history, it's important to know that. But give it 6 months, really. So, there are other ways to also detect ovulation I would not suggest going into, which is basal body temperature. It's very old-fashioned. It's extremely labor intensive. You're taking a temperature and charting it every day. You don't need to do that. It's what we used to tell patients 20 years ago, but they don't need to do that now. There are all sorts of very expensive and fancy urine analyte kits. I would say you don't, and it puts it onto a whole graph of your hormone profiling. I don't think patients need to entertain doing that either. But really, it's, trying to conceive, like a normal couple, not to overthink it. Obviously, if there's difficulty doing that, there's erection issues, he can't perform, you don't know if he's ejaculating, you don't know when you're ovulating, then I agree, patients end up coming to see a fertility doctor sooner rather than later. We can absolutely do the evaluation as whenever a patient wants, really. And so sometimes patients come in preconception and say, check his sperm and make sure it's okay. I want to know before I'm trying. And it's at your discretion. You absolutely can do that. We do ultrasound. We make sure that the uterus looks healthy, that there's no fibroids. We'll look at the ovaries. We look at your egg count. We can send them up to drop off sperm. We can do genetic screening, and then we can do some of the testing that I referred to, like your thyroid screening, your immunities, your blood count. So some patients really want to just do that, and we call that preconception consult, and that's your discretion. You absolutely can do it, but not required, not necessary. And if you are getting periods every month, you can be a normal couple and just really try to conceive. Patients who need access to care, right? They're going to use a donor sperm. That's a different story. They come in, they have to. We need to, purchase sperm and get the sperm and inseminate. So that's a different conversation. And I think that's it. I mean, other things to think about, travel plans. I always say, if you're young, travel now. You're not going to be going overseas much or doing long trips once you're pregnant. Early pregnancy is not the time to go out of the country either. If something happened or it's not a confirmed viable pregnancy, or you have bleeding in pregnancy, it's really hard to not be near your doctor. So, if you have plans to travel, or, your sister's getting married in 6 months, think about timeline in terms of that. Don't plan around your job. As a female that's had a big career, and I've had my own kids, there's never a good time in terms of work. So do what works best for your personal life. Job will always be there when you come back. But I do think, it's nice to be thoughtful about your timeline and, your medical history and GYN history. And it's okay to be vigilant and want to make sure that things are okay before going forward. So that's my little talk. I think there's a little chat. I know it's weird. I can't see who you are, but if you have questions, you can put them into a little webinar chat, and I will see a question And, oh, here's somebody's story. Okay, I'm 37, I just underwent laparoscopic surgery in March. Low AMH 0.1. Oh, so was a lot, I mean, I don't know if you can hear me. I mean, you'll write back to me. So for laparoscopy, I'm assuming it was for endometriosis. I could guess that, or something on the ovary that maybe you had surgery on. I'm wondering, was the AMH done right after your surgery, or was it known before your surgery? I don't love the AMH, I'm being very honest. So it's hard for me to tell you to just try on your own. I mean, like, you could try on your own for 2 months, it's not going to make a difference. But, if you had laparoscopic surgery for, let's say, endometriosis, or you had something removed from your ovary, I'm concerned with the AMH. So I think it depends on how many kids you want. If you definitely wanted more than one kid, I would say IVF. I mean, the benefit of IVF is that you can extract what you have now. You're never as young as you are now, ever. You're younger today than you are tomorrow. Extract eggs, make embryos, and save them. If you get pregnant on your own, amazing. Maybe you'll use the embryos for baby number 2. I will say, if it was drawn right after your surgery, it could just be a result that someone was, operating on your ovary. But I would be concerned that it's, endometriosis, which can lead to, infertility. It falls in the realm of, a large percentage of our patients that do have trouble getting pregnant. You'll never be regretful of making embryos. So you can go through a cycle, see if you can get embryos. And if you wanted to, try on your own, try on your own for some time. If you don't get pregnant, you have the embryos to go back on. But I can also speak to you offline, but let's maybe connect if you needed to. Here's somebody. My partner got a sperm analysis. It's 2% motility. 2% motility, 5.5% progressive growth, 10.6 million. 2% motility is extremely low. So normal motility is 40%. So this is what you have to think about, is total motile count. So if you take total motile, which is, his count, which is, let's say, 10 million times his 2%, it's extremely low. Total motile is very low. I don't think it's going to be hard to naturally get pregnant with that percentage of motility. I want you to clarify, if it's really 2%, number one, repeat it. Rule of thumb in medicine is to repeat the sperm analysis. Sometimes it's a collection issue. Sometimes he used a weird lubricant. Sometimes he had weird lotion on his hand and it killed all the sperm. The count's low, but it's not severe low. It's 10 million. Under 5 is severe. Under 15 is oligospermia, but it's not severe low. So I would have him repeat that first and foremost. And then if it's still abnormal, I would send him to my counterpart, who's a fertility urologist. Dr. Barham is our doctor at RMA, but there are local doctors, in the boroughs, local fertility urologists in boroughs. They would do an ultrasound on him, and genetic screening is big for him. Like, again, you want to make sure he doesn't have cystic fibrosis or something that would cause the sperm to have no motility. Does he have chronic lung issues? These are things you have to think about. But so I would, so the person who just put this question, please have him repeat it first, and then let's see what it is. There are supplements. Theralogics has a brand, Conception XR. I think the urologists use that a lot, but it's not going to fix a real low motility. But I'm wondering if that's a false low. That's low. Maybe he used something that killed the sperm. 2%. Oh, she wrote back. Did you repeat it? Oh, someone wrote 2%. Okay, that was you. I don't know if the supplements really don't improve motility. I would have him be seen by a urologist and let them do an ultrasound. But again, I would have him repeat it first. I've seen it where the motility is not great and then it's repeated and improved. I would say to you, it's hard to get pregnant with that low. Maybe you can try inseminations, but when it's that low, if it's really that low, it might be hard to be pregnant. So let's take into account your age. Someone else wrote here, can I get the immune injection required to go to school? I don't know what that means. Can you get a vaccine? I don't know which one that means. Oh, okay, she wrote this. Yeah, you're young. Have him repeat it. Also, I don't know if he did it at a fertility center. That's the difference too. You want to make sure that he's doing it at a fertility center, not at, for instance, LabCorp, or Sunrise Labs, where he's producing it. Do it at a real fertility center, whether it's us or another center, have him repeat it. But it's, the fact that you got a semen analysis, I think is uh, good. If you were trying for 7 months, it was worth it to get it. Yeah, but I've said this. Patients always ask me, "What's the best?" There's no best. I mean, whatever. There were ones that they all have the same folic acid. That's all I want it to have. Some patients, um, you could really generic prenatal is all the same. There are branded ones that look prettier. Some of them have fish oil as an extra supplement, which is good for neurodevelopment of the baby. I forgot to mention that. It's called DHEA. But sometimes it's hard to tolerate because the patient is having reflux of fish oil. So sometimes it comes as a separate pill in the prenatal pack. I think it's best to be separate because if you can't tolerate it, at least then you just take the regular one. But again, I would say these are the most common ones the patients are on. Perel, Ritual, Luminary, Theralogics, Nature Made. Those are the 5. If I could survey a room of, 90 patients, most of them are on one of those 5. So whatever is more accessible, look at the price points, but again, folic acid you need to be on. I don't know what this last question was. Can I get the immune injection required to go to school? Is that the MMR? Yes, but you can't get pregnant for 30 days. So that's again, no pregnancy, 30 days, it's a live virus. Yeah. So that's it. Any other questions? And if not, and anyone wants to connect with me, you can either reach out to the marketing team that set this up. If you could imagine, I don't even know my own office phone number. Let me get that. You can just call. You can always do telehealth too, or send me any of your records. I'm happy to look at anything. My office is 516-746-3633. You can email me. Agnes can give you my email as well. Someone wrote one more thing. 37. Oh, right tube working. Right tube working. But this is the same. This is the one that you had laparoscopy. I think if you can, for this patient that's calling in, if you want to set up a time, let's speak, because with the laparoscopy, the low AMH and the 1 tube, I think you should attempt to go through IVF. If you don't have insurance coverage, we could, there's ways that we can navigate that. So, if you really are not wanting, and listen, nobody wants to do IVF, but if you're really attempting on your own, then let's talk through it. There's always a chance if you have one open tube. Yes, there's always a chance. And then for the attendee with the low sperm, yeah, I mean, I want you to repeat it because I'm not sure I believe it, but if it's really 2%, I think it's going to have to be IVF. The reason it's because of it's obvious, it's not the count, it's the motility. IVF allows you to do something called ICSI, ICSI, which is intracytoplasmic sperm injection. So that's taking a sperm and pairing it with each egg. It's why ICSI was invented, is to specifically address very low motility, low count, or something called low morphology, how the sperm is shaped. So, but let's repeat it. I would say repeat it first because maybe it's an aberrant and it's not real. But if it is real, if there's treatment, you'll be fine. But sometimes you do have to do IVF. You can repeat it within 2 weeks. I would say separate. So if it's been 2 months, it's fine. You can repeat it. 2 weeks is the interval I would say to have it repeated up. All right. Well, it's nice to spend my evening with you. Keep me posted and good luck to everyone on their journey. Bye, everyone. Take care. Bye-bye.